Welcome back to Therapeutics. In this block, we'll talk about the pulmonary medications, and specifically in this particular slide set, we'll focus in on the drugs used in pulmonary medicine and focus on the asthma guidelines. We'll start off looking and reviewing the autonomic nervous system very simply as it relates to particularly the bronchodilators. We'll focus a little bit also on anti-inflammatory agents, particularly used in asthma and to some degree in COPD, with a particular focus on glucocorticoids. And this is in part a review of glucocorticoids that are covered elsewhere in the curriculum as well. We'll talk a bit about how drugs are delivered to the pulmonary system and some of the delivery devices that are used in asthma and COPD as well. So as a review, let's quickly look at the autonomic nervous system medications that are used for bronchodilation. If you remember our focus in the autonomic nervous system when we covered this earlier in the curriculum, we looked at focus specifically on the sympathetic and the parasympathetic systems. And we're going to really focus on the center two columns of this graphic. And we think in the sympathetic system, remember we have the electrical stimulation from the brain down through the ganglion, ultimately to the end effector organ. On the sympathetic side, releasing norepinephrine at an adrenergic receptor. And on the parasympathetic side, releasing acetylcholine at a muscarinic receptor. And the receptors of interest here in pulmonary, obviously, are the bronchial smooth muscle, that would involve in bronchoconstriction or bronchodilation. On the sympathetic side, if we stimulate the beta 2 receptor, the adrenergic receptor and the beta 2 receptors in the bronchioles, we'll achieve as an agonist at this receptor bronchodilation. And that's going to be our focus here. We also can innervate the parasympathetic nervous system by giving an antimuscarinic at specifically if we can deliver it to the bronchioles and limit it to that area, limit that antimuscarinic property just to the bronchioles, resulting again in bronchodilation. So when we look at bronchodilation as part of our modalities for asthma and COPD, we're going to really look at either using a beta-2 agonist or an antimuscarinic, or perhaps both, at the level of the bronchioles to achieve bronchodilation. So in review, in the lungs and the bronchioles, giving an agonist and a beta-2 sympathetic receptor is going to result in bronchodilation. If we gave an agonist in the parasympathetic side, we would get actually bronchoconstriction. Clinically, we don't want to do that in folks with asthma, although there is one slight exception. In pulmonary function testing, we sometimes want to see the reactivity of the airway, and in a very controlled environment, under the supervision of a pulmonologist, a patient may actually go for a methylcholine challenge, and that's a parasympathetic agonist that would induce bronchoconstriction. But that's a very limited situation. Clinically, for therapeutics, we would do the opposite. We would want to give a parasympathetic antagonist at the level of the bronchioles to allow for bronchodilation. So when we focus on asthma specifically, we're going to have two-pronged approaches. We're going to look at opening the airway primarily with the bronchodilator. That could be a beta-2 agonist, that could be an antimuscarinic. There are a couple of the bronchodilators that have been used over the years. The one that still is used to some degree that's not either of those is theophylline. It's a caffeine derivative or related to caffeine. It's a methylxanthine. We'll talk a bit about that. In addition to opening the airway with a bronchodilator, a beta-2 agonist, or an antimuscarinic, we're also going to look at reducing inflammation. And there are lots of things that we can do to do that. The primary way we're going to look at doing that is with corticosteroids like prednisone-like drugs, either inhaled or oral or IV. We also will look at other mediators of inflammation and look at how we can trigger those, and probably in at least asthma management, leukotriene antagonists are probably the most commonly used other anti-inflammatory agent we see. There are some other options as well. There's a phosphodiesterase 4 inhibitor that's used in end-stage COPD. There are older mast cell stabilizers, and there are monoclonal antibodies directed against either IgE or affect eosinophils, which might be high in refractory cases of asthma. Let's spend a little time talking about the beta agonists, bronchodilators, and starting first with albuterol. Albuterol's been around for a long time, and it is specific for beta 2 agonists. The advantage is that it has a relatively quick onset of action, and its duration is probably around 3 hours or so. So it really is our rescue short-acting inhaler. There is a levoalbuterol form, which is the levorotatory form, of albuterol. Let me explain what that is. Most drugs that are delivered on the market these days are called racemic mixtures. They're a 50% mixture of a right-handed and a left-handed version of the drug. So what do we mean by that? If you open up your hands, look at your palms, you'll see that your left hand has 4 fingers and a thumb, and your right hand has 4 fingers and a thumb. And in a 3-dimensional field, they're mirror images of each other. And most chemical structures are this way as well. That 50% of albuterol is the levorotatory form, the left-handed version, and 50% is the right-handed version. The advantage of levoalbuterol is that that's the formulation. The left-handed version is the formulation that binds to the beta-2 agonist receptors and achieves the benefit we want. For almost every patient, the dextrorotatory form of albuterol doesn't do anything. There's been some debate about whether a very small subset of patients that may cause binding to receptors that cause worsening of asthma, but that issue has been largely debated and is probably clinically not relevant for the great majority of patients. So the bottom line is almost everybody is well managed just on plain albuterol, which is a mixture of the levo and the dextrorotatory forms of albuterol. So albuterol in review is a selective beta-2 agonist used for bronchospasm. It is short onset and not a long duration. It's what we call our rescue inhaler. It's the inhaler that patients are going to use when they have an acute attack of some kind. That's the one they're going to reach for, that's going to work more quickly. As we alluded to, levoalbuterol probably doesn't have clinical advantages over plain albuterol for the great majority of patients. When patients have asthma particularly, we look at measuring their forced expiratory volume over the first 5 or 6 seconds, particularly looking at that first second, that forced expiratory volume in the first second. And folks who have bronchospastic airway disease, you might measure that, give them a dose of albuterol, and then measure it again. And what our expectation would be is if their bronchospasm is responsive to a beta-2 agonist, their FEV will improve after the albuterol. Some other bronchodilators that we're think about are the longer-acting beta-2 agonists. Here we have formoterol and salmeterol are sort of traditionally the ones that have been used the longest, but there are others on the market as well. They have an onset that's almost as fast as albuterol, and their duration is up to 12 hours. So they offer some real advantages, long-term maintenance therapy over albuterol. And formoterol particularly has a quicker onset maybe than some of the other beta-2 agonists, and so you'll see some of the guidelines might even consider using formoterol both scheduled and as a rescue inhaler. We'll come back and talk about that new recommendation from the GINA guidelines in a little bit. The other 2 agents that are listed here, isoproterenol and epinephrine, are not recommended. they bind to beta 1 receptors, and so they cause cardiac stimulation, and epinephrine also binds to alpha receptors with vasoconstriction. And so both of those are not modalities we recommend, even though epinephrine or Primatene Mist is still sometimes available in some areas over the counter. That's really, most clinicians consider that a dangerous practice because epinephrine is short-acting, it binds, causes tachycardia, causes elevated blood pressure, and as an over-the-counter product, patients really aren't getting the supervision they need and the access to the anti-inflammatory component of asthma management. Other bronchodilators include the antimuscarinics, ipratropium short-acting, and then there are some long-acting ones here as well. We're going to focus on all of those more so in COPD than we are in asthma. But we do use ipratropium short-acting by nebulizer, often in combination with albuterol, and that's a product called Duoneb, and that's very common in acute care settings where patients who have any bronchospastic airway disease get the nebulized treatment of albuterol with ipratropium. One of the last agents we'll talk about here is the older theophylline product, the methylxanthine, and we'll talk about that in just a minute. So there are lots of antimuscarinics. Ipratropium is the short-acting one. Tiotropium is an example of a longer-acting one. Again, more in COPD than asthma. And theophylline, an older preparation, has been around for decades. It's caffeine-related. It's a methylxanthine. Problem is it's a narrow therapeutic index drug. And while it does cause bronchial smooth muscle relaxation, probably by inhibition of phosphodiesterase, it causes central nervous system stimulation. It causes cardiac stimulation. It is a narrow therapeutic index drug. It has a lot of interactions with other drugs, including macrolides, azithromycin, for example, which is commonly used in COPD patients, causing elevated theophylline levels. And so it's a drug that has a really pretty limited role.
Let's switch gears and look at some of the anti-inflammatory agents that have been around for a long time and standards of care for asthma management and in late-stage COPD as well. The corticosteroids are the mainstay here for anti-inflammatory agents, and they will look at inhibiting inflammatory responses by inhibiting COX-2 and also have a number of other effects on other cytokines, including interferons and interleukins. They also have a number of other effects that we'll walk through. We talk about the corticosteroids throughout the curriculum, particularly in other disease states as well. We talk about them in dermatology. We talk about them in rheumatology, in treatments for MS, and in GI as well. But here we'll sort of review these and really focus more on inhaled corticosteroids. By inhalation, inhaled corticosteroids are the mainstay with bronchodilators for asthma management. They're also used in later stage COPD as well. The advantage of inhaled corticosteroids is that they will quell or they'll keep inflammation a bit at bay and prevent future inflammation to a moderate degree in patients without a lot of adverse effects. You might have some topical or local effects in the oral candida with oral candidiasis or for irritation to the larynx or voice changes or throat irritation, but that's really most of what you have for problems with inhaled corticosteroids. Not much is systemically absorbed. The other side effects that are listed on the bottom of this slide, including hypothalamic pituitary axis, adrenal axis suppression, or cataracts, osteoporosis, growth retardation, are really pretty limited with inhaled corticosteroids because you don't really absorb very much. So you don't really expect those. Those are more theoretical adverse effects than clinically seen actual adverse effects. When we're using inhaled corticosteroids, we want to make sure that patients know how to use their inhalers. We'll talk much more about that in a little bit. They might look at using a spacing device. We'll talk about that. And then rinsing their mouth after they have used the product would lower their risk for oral candidiasis. Most patients don't even have to do this, but if they do have candidiasis with an inhaled corticosteroid, then we definitely would recommend rinsing after inhalation. We also will use systemic corticosteroids, prednisone or methylprednisolone, in acute asthma exacerbations, and we also actually use them in acute exacerbations of COPD often as well. We'll talk more about that in the COPD block. But when we need these therapies that are systemic, these are going to provide a much greater degree of anti-inflammatory property than the inhaled corticosteroids can do. And so if somebody's really in an acute situation, we want to give them uh, systemic corticosteroids as opposed to just inhaled corticosteroids. We can do that IV, methylprednisolone, if they're really in tough shape, or oral with oral prednisone. And usually we'll give something in the range of about a milligram per kilogram per dose. With IV methylpred in the hospital, typically we'll give them something like for an adult, either 60 or 125 milligrams of methylprednisolone IV every 6 hours for 24 hours, and then taper that down over the next few days. Our goal here is to use pulse therapy for something in the range of 5 to 7 days or so, with tapering doses. That slow taper might be something like we start them on methylprednisolone for a day, high dose, and then low dose methylprednisolone for a day. And if they're doing well, we switch them on day 3 or 4 to oral prednisone, 60, 50, 40, 30, 20, 10 off, something like that. But we really don't want the duration to be more than a total of 14 days, if that's at all possible. So we really do our best to kind of make that limit systemic corticosteroids. There are lots of available routes of administration for corticosteroids: intravenously, oral, by inhalation, either alone or in combination products, and we'll go through some of those. The IV formulation, methylprednisolone or hydrocortisone, are very commonly used in the hospital, particularly methylprednisolone. And then orally, prednisolone in pediatrics, or dexamethasone are all oral corticosteroids that could be used as well. Some of the other anti-inflammatory modalities we have, one of the agents that's used in end stage or refractory asthma, maybe not end stage, but refractory asthma by the pulmonologist, is Xolair. Xolair is a monoclonal antibody directed against IgE. So if we know that a patient has an IgE-mediated reaction, and that poses a risk for their asthma, they might be a candidate for this. But there's a lot of hypersensitivity reactions to this product. It's expensive, and so it's an agent that's really ordered only by the pulmonologist. We'll also share a couple of other sort of similar approaches to care, some of the new modalities in the last year or two for patients who have asthma and high eosinophil counts. And there are new modalities, also expensive and have side effects, that could be used by the pulmonologist in those realms as well. And when we get to the end of the guidelines, we'll talk more about those. But those really under the purview of the pulmonologist. More commonly in asthma management early on are the leukotriene antagonists that inhibit inflammation and result in leukotrienes that trigger bronchoconstriction. The three leukotriene antagonists that are available are Xyleuton, montelukast, and zafirlukast, but really it's only montelukast that's widely used. Montelukast, or Singulair as a brand name, is available orally. It's 5 to 10 milligram dosing, available in pediatrics, and they really do reduce inflammatory reactions and are what we call corticosteroid sparing. Patients who do have asthma often do well with Singulair. They don't have to use the beta-2 agonist rescue inhaler as much, and they don't need steroid rescue therapy as often either. One of the last anti-inflammatory agents that's limited to COPD only is Dalaresp, which is a specific agent affecting phosphodiesterase type 4, reduces inflammation. But it's a problematic drug in the sense that its adverse effect profile is really not great. It has some suicidal ideation in some patients, can exacerbate underlying mental health conditions that's associated with weight loss, GI intolerance, a lot of drug interactions. And so we really limit it to end-stage COPD patients. For those patients, though, it is associated with an improvement in their inflammatory response to their COPD, but this is an agent that's pretty much only ordered by the pulmonologist. Really, one of the last and really rarely used anti-inflammatory agents now are the mast cell stabilizers like cromolyn. Cromolyn works on stabilizing the mast cell from degranulation. So if we think about it, if a patient has an IgE-mediated reaction, the IgE, after exposure to the antigen, binds to mast cells. Then on re-exposure to the antigen, that antigen binds to those binds again to the mast cell, to these sites, and ultimately leads to degranulation of the mast cell, releasing histamine and leukotrienes and other chemical mediators that predispose to the reaction. So agents like cromolyn stabilize mast cells, but the downside to these agents is that they really require 4-time-a-day dosing by inhalation for long periods of time. Their only help with prevent future events. You have to be on them for weeks for it to be offering any benefit. And so it's really not a widely used modality and sort of limited in its scope and its use. But it's available for folks where nothing else has worked. Let's shift gears a bit and just talk about the general principles of corticosteroids in general, mostly as a review here. So we think about the corticosteroids. We start with the pituitary that the mechanism of action of corticosteroids affects the control of synthesis of adrenocortical hormones. And cortisol, which is ultimately produced here by the adrenal gland, has both mineralo and glucocorticoid activity. We'll talk about those two principles of mineralo and glucocorticoid in just a minute. If we look at the nature of how the mechanism works, the hypothalamus releases corticotropic releasing hormone to the pituitary, which then secretes adrenocorticotropic hormone to the adrenal cortex, releasing cortisol. And cortisol, as its glucocorticoid functions, include anti-inflammation, affects glucose and protein synthesis and inflammation, but also has what we call mineralocorticoid effects affecting salt and water. The mineralocorticoid effects that we think about with corticosteroids are aldosterone-like effects, where we see an increase in sodium reabsorption with ultimate fluid shifts and edema, a little raise in blood pressure, and a relative decline in serum potassium, and also more hydrogen ion secretion as well. And so mineralocorticoid effects, while they're necessary for maintaining blood pressure and maintaining homeostasis and fluid balance, in patients who are receiving exogenous sources of corticosteroids where there's a lot of mineralocorticoid effects, we worry about, for example, patients with heart failure or patients who have fluid accumulation where that's problematic. The glucocorticoid effects, there are multiple ones we think about when we're giving agents like prednisone or any glucocorticoids, and they affect hepatic gluconeogenesis. And so what we're going to end up with is seeing a change in glycemic control. We also see over time fat redistribution, and we'll see, for example, facial fat distribution and fatty lumps on the back, for example, pretty common with excesses in glucocorticoid activity. You'll also potentially see with glucocorticoid high dose changes in mood, elevation in mood, sometimes excitability, behavioral changes, but it can go to irritability to psychosis, and so we're worried about that. We also see that some of the changes that happen with glucose control and blood pressure control and neurotransmitter regulation are affected by all of this as well in a more indirect kind of way. Glucocorticoids also affect bone metabolism, ultimately resulting in osteoporosis by multiple mechanisms. And we see what classically is seen a shift to the left with glucocorticoids, a redistribution of white blood cells from the attached to the margins of vessels to now go into circulation. And so the classic thing we think of and what you'll see in clinical practice very commonly is on day one, the patient's admitted to the emergency department, for example, with asthma, COPD. They get doses of methylprednisolone, and on day two, you get the morning labs, and lo and behold, the white blood cell count is elevated. And then you think, well, what's going on with this patient? Did they have an infection? And so you could work them up for infection or not. What we're going to look at is the differential white count. The differential white count on day two after prednisone, if we see a shift to the left, if we see more bands, more immature cells, that's indicative of infection, a true infection, coming from the bone marrow, newly developed white cells secreted from bone marrow in response to infection. If, however, there's no infection, but in fact it's the prednisone effect, what you see is not a shift to the left. You don't see an increase in bands, but you do see an increase in total white blood cells. That's because some of the white cells that were hanging on the margins or on the vessels, on the wall of the vessels, get released into circulation, and so that's in a sense an artificially elevated white count. Important information for us to recognize. We also see, and the main reason we're probably using glucocorticoids is its reduction in inflammation. And that's a beneficial effect. Usually when we use it, certainly in asthma, COPD, we want that so we have less mucus production and swelling, airway occlusion happening. But the other issues with immunosuppression we worry about is an increased potential for infection. And usually it's a moderate decline in immune status when folks are on prednisone. And if the inflammation is significant, reducing the inflammation is a more important value for us than we would see just the effect on immune status per se. Keep in mind that normally cortisol secretion for folks who sort of have a sleep-wake pattern that is daytime awake, nighttime sleeping, which is most patients, we see an increase in cortisol secretion in the morning. And so for most patients, when we put them on prednisone or a corticosteroid once-a-day regimen, we like to dose that in the morning to mimic the normal secretion of cortisol. Where this runs into a little difficulty is the patient who has for example, works the night shift. And so when are we going to dose their prednisone? Probably at the point in time when they first wake up at the beginning of whenever their day starts. But that's an issue we think of with cortisol per se or glucocorticoid timing. For aldosterone, the mineralocorticoids alone, those really don't have a lot of variation in the time of day in their serum levels. And so that's less of an issue for us usually. I think it's important as a clinician to keep in mind this chart of comparing the available glucocorticoids, particularly in their relationship to how much is gluco versus mineralocorticoid. And cortisol is the naturally occurring substance, which is about 50-50 of each. And that's important because you want to recognize that the mineralocorticoid effects will affect salt and water accumulation, but that's a necessary evil for patients naturally to maintain blood pressure if they have hypotension. So we'll look to mimic, for example, someone who has Addisonian crisis, for example, or someone who needs more cortisol. We'll often mimic that with hydrocortisone. That's the advantage hydrocortisone has. But if we're looking primarily for the glucocorticoid anti-inflammatory properties, we often will go with methylprednisolone or prednisone, which has less mineralocorticoid effects. And that really serves a purpose for us. Finally, dexamethasone is all glucocorticoid, doesn't cause salt and water accumulation. So in cases where edema is an issue, for example, cerebral edema with brain mets in cancer patients, dexamethasone is a great drug. Where dexamethasone would not be appropriate is for someone who has a suppressed hypothalamic pituitary adrenal axis, where they're not producing cortisol, you want some of that mineralocorticoid supplementation. And in those patients, we usually go with hydrocortisone. Finally on this list, and it's not really related to inflammation at all, is fludrocortisone, is all mineralocorticoid, and that's typically limited to patients who have very significant orthostatic hypotension and don't it's not managed by anything else. And that's not going to affect really the pulmonary patients we're looking at focusing here on. As we alluded to, there are lots of different routes of administration of glucocorticoids. We're going to focus here mostly on the inhaled forms or the systemically administered forms. And as a review, the adverse effect profile of glucocorticoids include changes in appetite, mineralocorticoid effects of edema and elevated blood pressure, and then all the other things we alluded to. The risk for immunosuppression, impaired wound healing, changes in calcium balance and osteoporosis risk, changes in mental status, and lastly, but probably not significant, is a potential risk for GI bleeding and peptic ulcers. And so that's going to be usually for most patients a minor issue. There are a number of interactions that happen with corticosteroids. We need to be aware of those when we're starting and stopping other drugs, when folks are on prednisone or prednisone-like drugs that can be implicated here. And the hypothalamic pituitary adrenal axis suppression really only happens when folks are on longer term, more than 10-day therapy of prednisone at doses above 10 milligrams a day. That's typically what you'll see. And if somebody does have not secreting their own cortisol and they run into trouble, you typically see Addisonian features, which include weakness and fatigue, anorexia, sometimes nausea, vomiting, and hyponatremia. Hypotension is classically presented as well. Typically, that's going to happen with longer-term therapy and with larger doses. As we briefly alluded to, the peptic ulcer disease risk is probably minimal in most patients. Usually, we don't worry about it. If a patient has a GI bleed risk, we might want to sort of up the ante on how we manage acid suppression for them, but usually not a big issue. We can see psychiatric effects with big doses of corticosteroids, usually systemic. This wouldn't be an issue usually for inhaled corticosteroids, but higher dose corticosteroids, you can see changes in mental status, and that's important for us to be aware of. And usually we see it early on in the onset or of the corticosteroid or an increase in the dose of the corticosteroid. One of the last adverse effects that's usually not an issue is the rapid administration of large doses of corticosteroids. This wouldn't be normally in pulmonary patients. This might be in a spinal injury trauma patient for whom we have to give high-dose methylpred over a short period to reduce inflammation in the spine and prevent paralysis if we can. But we see fluid and electrolyte changes with the mineralocorticoid effects and increased risk for sudden cardiac death. So these patients, if they have to administer big doses of corticosteroids IV rapidly, we often put them on telemetry. So we use a lot of corticosteroids for a lot of indications. In pulmonary, typically it's a mainstay of asthma, but also we see it used in COPD as well. Let's now just spend a few minutes looking at how we deliver drugs and the delivery systems we use to get the drugs into the lungs. When we're looking at giving an agent by inhalation, either a bronchodilator or an anti-inflammatory corticosteroid, we need to make sure that the particle that's delivered or the liquid that's delivered is a small enough droplet or a particle size that it's going to actually disperse deep into the bronchioles. That's really an important consideration for us. And so how effective we're going to deliver that drug to where we want it to go is a function of the particle or droplet size, is what's the rate and depth of the patient's breathing. Are they able to hold their breath to allow for an adequate delivery and penetration of the drug to that area? The advantages of inhalation is they work quickly and they reduce a lot of systemic effects. And so we use a lot of drugs, really pulmonary administered drugs, particularly bronchodilators, but also inhaled corticosteroids, really deliver the drugs where we want them to produce the effect without having to go systemic. When we do administer drugs by inhalation, be it corticosteroids or beta 2 agonists or to some degree antimuscarinics, some of the drug obviously gets to where we want in the bronchioles, but some of it gets, plastered in the oral pharyngeal cavity, gets swallowed, and then ends up with being absorbed into systemic circulation. So it's important for us, I think, to recognize that this is a continual phenomenal process for us to be aware of. There are a number of delivery systems that are used, but they fall into two broad categories, either nebulizer or a variety of different types of inhalers. Nebulizers offer the benefit of not having to really coordinate or be as active in coordinating the patient's breathing pattern with the delivery of drug, whereas the inhalers vary in their device structures and whether they use dry powder or not, and also whether or not the coordination of the patient's breathing with an activation step or not might be involved. And we'll sort of go through some of these examples in the next few slides. So these tables in the next few slides will list a lot of sort of detail that is not really important, I think, at this juncture to really focus on. But really across the first row are the meter dose inhalers. These are inhaling devices that usually have a canister involved with them and a mouthpiece that have to get activated. You shake the canister and then you coordinate the placement at the mouth, exhalation, inhalation, and activation during the first portion of inhalation for the patient. They usually benefit from using some kind of a spacing device so that the particles are aerosolized and assist with patients, particularly who have trouble with coordinating breathing and activation of the device. The most common agent in this group of meter dose inhalers is probably albuterol, the rescue inhalers, but there are other devices that are commonly used that fall into this kind of situation as well. There are also dry powder inhalers that either are single dose or multiple doses. Single dose inhaler involves the HandiHaler Spiriva is a classic example here, where the patient has to take a capsule and put the capsule in the device, close the device, and then use the device to inhale the powder that's in that capsule. And important in education that patients know this capsule is not an orally administered capsule. It's a capsule that's meant to be delivered in the device to be inhaled, inhaling the dry powder. There are a number of multiple preloaded dose dry powder inhalers and different brands. They have different sort of device structures, and so you'll see sort of they look differently. And we'll show some images of some of these inhalers in a little bit. But there are a number of them that are on the market. There are also breath-activated dry powder inhalers, and these are helpful for patients who have trouble coordinating their inhalation with their breathing. And there's a product that's available, a Respiclick albuterol inhaler that might be good for patients who have trouble activating, coordinating breathing with activation. And there are also some soft mist inhalers as well on the market. Nebulizers, on the other hand, have an advantage of being less dependent on the patient's technique of inhalation. And some of the nebulizing solutions are cheaper than these dry powder inhalers, but the disadvantage is that the patient has an upfront cost with the nebulizer, and they're more cumbersome to use. They're bulky, although there are some portable nebulizing devices now that are pretty small in size that make it more sort of portable to use. The metered dose inhalers, many of them on the market, lots of the products that we're going to look that want to be delivered, whether it's short-acting beta agonist, inhaled corticosteroids, long-acting beta agonists or combination products or antimuscarinic short-acting antimuscarinics are all available in this device, and most of them have a canister that has to be sort of activated in some way, shape, or form, and delivered to aerosolize the product that has to be coordinated with inhalations. So the classic steps in a metered-dose inhaler inhalation technique is important for patients to do that. And we find that patients have a lot of education that's needed here to use their inhalers correctly. And even though you think patients do well, a great majority of patients really don't use their inhalers well until they're taught well. So I would encourage you to do a couple of things here. One is if you have anyone in the class, for example, has asthma, uses their inhaler, they could demonstrate how to use their inhaler to other members in the class. Or if you know someone's on an inhaler, ask them to show them how you use it. But also online, there are a number of videos that are examples of how to appropriately use an inhaling device, coordinating breathing with that. And also spend a little time in your clinical year with a respiratory therapist. All of those are really valuable, so you know how to appropriately use these devices. The standard approach for the classic canister-based metered-dose inhaler is that the patient, you want to make sure that the patient has a full dose or has a full dose left in that canister. So there are ways that patients can find that, A, their inhaler really is not empty, and that they always have an inhaler ready for them that has product in it, that they remove the cap, they shake the canister inhaler, they coordinate the placement of the inhaler either around their mouth or closing their lips around it, depending on the technique they use, tilting their head back, breathing out as fully as they can, starting an inhalation, and early in that inhalation, activating the canister, continuing to breathe in as deeply as they can for 3 to 5 seconds, and hold their breath as long as they can. Ideally up to 10 seconds. That's hard to do for patients who are having an acute attack, but the best they can do is what we shoot for. And then exhale, and then if they need a repeat dose, repeat a minute or a couple of minutes later. If the product delivers product in the back of the mouth that causes irritation, or if there's an inhaled corticosteroid, they may want to rinse off, gargle with warm water, and then make sure they're cleaning their device appropriately, wiping it down as appropriate. A number of patients, particularly pediatrics patients or patients who have trouble coordinating other kinds of inhalers, the dry powder inhaler, we alluded to the capsule that has to get put in the device for inhalation. There's a couple examples here. Or there are other single-dose dry powder inhalers that have to get activated with the product each time they're used. There are multi-dose or dry powder inhalers that are preloaded on the market. There's the Advair Discus, which is in the upper right-hand corner. There's a different brand of inhaled corticosteroid, budesonide, Flexahaler. There's a long-acting muscarinic antagonist, Pressair, that's shown here in the upper right. There is another inhaled corticosteroid, dry powder inhaler. So each brand has sort of a different look to their inhalers. The techniques are subtly different in how they activate their next dose and how they coordinate their inhalation. A product line that is delivered for once-a-day dosing is done. These Ellipta inhalers from GlaxoSmithKline, and they have their product line. These inhalers, by the way, almost all of them are in the range of $100 or $200 a month, unless there's a benefit. These are sort of expensive products for patients. But the inhalers, these kind of dry powder inhalers, are available in lots of combinations. They are, available as long-acting beta agonists, long-acting muscarinic antagonists, combinations, or combinations that would include or don't include inhaled corticosteroids. So lots of different kind of choices that are available. and yet more of the elliptica inhalers shown here as well. The breath-activated dry powder inhaler, the ProAir Respiclix is an example of another one. And the advantage this has is that it helps in patients who have a little more difficulty in activating the inhaler and coordinating with their inhalation. And finally, another sort of set of devices are the inhalers that instead of a dry powder, deliver actually a mist of drug, a sort of liquefied mist form of the drug. So let's sort of look at all of the products that are kind of available. And again, the next sets of slides have lots of tables with a lot of detailed information. You could use this as a reference. I think the focus here is I just want you to be aware of the different classes of drugs. We're going to talk about where they fit. Later on, we look at the GINA guidelines, or when we cover COPD, we'll look at the GOLD guidelines on where they fit. But be familiar with the different categories, and then when it comes time to say, hey, I need a whatever category it is, you could either go to this table or go to the references or the resources you've got to find what's the available inhaled device, for example, that is available for a patient that is basically covered by their insurer or covered on the formulary of whatever their formulary is. So the first group of agents that at least I think of often are what is available for a short-acting beta agonist. And there are really a couple of choices here, but usually what we have is either albuterol metered-dose inhaler or albuterol as a nebulized solution. And those are pretty commonly used. There are a lot of different products that are available, and you'd sort of pick which one is available from on formulary or on that covered by that patient's insurance. We also have the long-acting beta agonist. Long-acting beta agonists, there are a number of them on the market. In asthma specifically, we don't see a lot of long-acting beta agonists alone used because we roll in the inhaled corticosteroids. So more commonly, instead of a single inhaler with just a long-acting beta agonist, we're usually going to pick one that also has a corticosteroid in them. But in the COPD management block we'll talk about in the next sets of slides, we do in fact use alone without corticosteroids long-acting beta agonists, a number of them listed here. We also have short-acting muscarinic antagonist, ipratropium, that's available both as a metered-dose inhaler, which could be used in COPD, but is more often used in at least acute care settings as a nebulized solution, and even more often as a combination with albuterol. We'll talk about that in a minute. There are long-acting muscarinic antagonists. Again, these are more often going to be used in COPD than they are in asthma, but there are a number of them that are on the market. We also have a combination short-acting beta agonist and short-acting muscarinic antagonist. And there is a combination metered-dose inhaler for this, a Combivent, but much more commonly, at least in acute care, we very commonly use the ipratropium albuterol nebulized solution called Duoneb. And that's almost a standard in most patients who are in the hospital for their bronchodilator of choice. And in fact, in acute care, we often don't use long-acting beta agonists, don't use long-acting antimuscarinic inhalers. We typically give frequent dosing of either albuterol by inhalation, ipratropium by inhalation, or more commonly that combination as our choice for giving inhaled bronchodilation. We also have combinations of long-acting beta agonist and long-acting muscarinic antagonists. Those are almost always limited just to COPD. And we have a lot of inhaled corticosteroids, which are very commonly used early on in the management of asthma. And so we have just corticosteroids alone. Sometimes folks early in the management of asthma will get a albuterol inhaler as their bronchodilator and will get just an inhaled corticosteroid alone to take on a regular basis. That's not uncommon to do. There's a fair number of inhaled corticosteroids alone. Pretty commonly, though, as we step up asthma care for many patients, it's an advantage convenience for them to include an inhaled corticosteroid with their long-acting beta agonist as a single inhaler and a single dose. And what we see classically here, a number of different agents. The two ones that have been on the market the longest probably are Symbicort and Advair, but there are others as well. And the choice of which agent and which dose is going to be used is usually a function of what's on formulary. Most of these have a standard dose of their long-acting beta agonist, but they might have a low, a moderate, and a high dose regimen for the corticosteroid. And as we'll talk about, a lot of these regimens will have varying doses of corticosteroid based on where they are in sequencing of their disease. One of the last sets of slides, tables here that involve some of these agents include a combination product of an inhaled corticosteroid with an antimuscarinic long-acting and a long-acting beta agonist. And this is usually limited to end-stage COPD, but might also be an option for certain asthma patients who are refractory to other therapies alone. And then finally, some of the other sort of anti-inflammatory components we look at that are listed here. First is the monoclonal antibody against IgE, Xolair. We talked briefly about this. This is only going to be used by the pulmonologist, for example. We do have the leukotriene modulators, and montelukast singulair is very common here, typically dosed once a day in the evening. Typically in adults and adolescents, it's 10 milligrams a day. In children, it's 5, or in very young children, age 1 to 6 years, 4 milligrams. Very well-tolerated drug. Adverse effect profile is pretty minimal with Singulair, well-tolerated, and it will offer some anti-inflammatory properties as a leukotriene antagonist. So really, we will recommend it almost with everyone with significant asthma. The last group of agents that treat asthma, the anti-inflammatories, are the agents that will impact on eosinophils. And such agents are often the monoclonal antibodies that are really ordered only by the pulmonologist in severe cases. They're expensive. They have adverse effects associated with them, including hypersensitivity reactions. And so we're going to be really cautious about who gets these. And they're also going to be limited in part by what the insurer will cover.